Good afternoon, everyone. Thank you, Dr. Arisha, for kind words. And thank you, ma'am, Mala ma'am especially, for inviting me and giving this opportunity to talk on this topic. So, routinely, we all do nerve conduction studies at our department only. We do it both in children and adults. There are some concerns in children, but still we tend to do it. I will be talking very basics about nerve conduction, how it arises actually. In the 18th century itself, a Leyden jar was invented just to by Van Mussenbroek to store electricity, and this was the jar which he used in his lab to store by the mechanical factors. This was the mechanical one he used to produce energy, and this energy was converted to electricity in this jar, and he was using this electricity for his experiments and everything. So it was Galvani was one scientist contemporary when he was doing some dissection on frog. So he suddenly some other colleagues were working on that Leyden jar. So suddenly a spark was there. He was using a metal knife to cut and doing dissections. Galvani. So some spark was there in the Leyden jar, and it produced through that knife. It produced a convergence in the frog. So first time the concept of animal electricity was invented by Galvani only. He said that probably there is some transmission or some nerve conduction going on. There is some electric energy in the animal itself that produce that convergence. Though this was a controversial till one century, it was a controversy by Volta or another scientist. He said probably it is not there because two metals were there and in between frog was there, so stimulation was there. So there was controversy, but ultimately the Galvani was right, and now we see that there is nerve transmission, electrical transmission through our nerves, and that stimulate our muscles, and we do activities with that. So this was the, and it took almost 2 centuries to develop this newer technique of machines which we use now. In 20th century it got developed. Different parameters of the nerve conductions were gradually invented by various scientists in this area, and now it is so useful in various neurological disorders which we see. So first of all, the anatomy, why how the sensory nerves and motor nerves which we study in nerve conduction, how they are different. So we can see in the sensory nerve, when there is a sensory receptor peripherally, and then the sensory nerve arises from that, and there is a dorsal root ganglion before it forms a sensory root and it reaches to the spinal cord. So the dorsal root ganglion is there, which is not there in the motor nerve. So motor nerve, there are receptors, muscles, then neuromuscular junction, then there is motor nerve, then motor root. It joins the anterior horn cell which is there in the spinal cord. Though this is a part of lower motor neuron system, it is a part of lower motor neuron, but it's there in the spinal cord. So from the anterior horn cell, the motor root is there, motor nerve, and then it stimulates, it forms the neuromuscular junction, and it stimulates the muscle, and we do activities. So these are the differences, and based on the differences, the nerve conduction studies also differ in this, and anatomical lesion and localization of that lesion also differs. So we need to know that this reflex arc, there is a sensory when we stimulate a muscle, or when there is reflex, we know when the muscle or tendon is stretched, there is a sensory nerve stimulated, it goes to the dorsal root ganglion, to the spinal cord. From there, through a synapse, it reaches the anterior horn cell, and to the motor nerve it comes to the muscle, and the reflex is produced. So this also I will talk later what is the importance of that. Based on different diameters and the conduction velocity and myelination, different kind of nerves have been classified. So there are myelinated ones, unmyelinated. This is just for information that based on the fiber diameter, the largest diameter fibers are A type, then B and C, and based on the diameter the velocity is also there. So larger diameter fibers, they are myelinated, they have more velocity, they conduct faster, whereas the lower diameter fibers, they have less velocity. So in nerve conduction study, we mainly target the largest and fastest myelinated conducting fibers. Smaller ones we cannot detect on nerve conduction. So basic electrophysiology which we do, we cannot tell about the smaller conducting fibers, that is small fiber neuropathy, we cannot detect that because this velocity is so low that we cannot detect it even using amplifier. So we are measuring just this largest and fastest myelinated fibers. So what is the principle how this transmission occurs? So there is initiation, then propagation of current, and then synaptic transmission to the muscle, and there occurs the movements. And then there is role of receptors and neurotransmitters. So at the axon hillock, where this is the body of the nerve, and where these axons arise, here the transmission starts. So whenever a electrical stimulus is given, there is some potential chain in there is a resting membrane potential is there, and to minus 80 to minus 90 millivolt potential is there. And when we apply electrical stimulation, there is change in potential in that area, and because of this sodium potassium channels which are there at these areas, because of this potential change there is, so this is resting membrane potential, negative is inward, potassium is more inside, sodium is outside. When we provide a stimulus, so sodium starts going inside, because of that potential difference it starts going inside, and there is depolarization here, it is start, and gradually this depolarization occurs throughout the nerve. And behind it, there is a refractory period for 1 to 2 milliseconds. The sodium channels are open, sodium goes in, and then there is inactivation. Sodium channels has actually two gates, one is activation gate, one is inactivation gate. So once there is a inward flow of sodium, so activation gate is open, the sodium goes inside for 1 to 2 milliseconds, it goes and goes inside, and then the inactivation gate opens, so no more sodium can go inside, no more sodium can go outside. So this is the refractive period. So whenever the nerve transmission is there, it is never in the retrograde direction, so it is refractory area. Now no conduction can occur, so only forward conduction is there, and that is important physiologically, and that we measure. So this is initiation. And then how propagation occurs. So propagation in two kind of nerves occur differently. So there are myelinated nerves and there are unmyelinated nerves. In the myelinated ones, so there is myelin, and in between there is nodes of Renvier where there is no myelin. So sodium channels ki density is more on those nodes of Renvier, and the myelinated ones are insulated. So when the current starts, it jumps from node to node. In between there is no transmission, no channel opening, no transmission. So from here the depolarization will occur here, where the sodium channels are more, sodium goes more inside, so it will be like this. So they jump from node to node. So the conduction is faster at these myelinated ones. So that is why the myelinated neurons have more conduction, faster conduction, and the potential is less lost between the membranes, because in nerves those are not myelinated, the conduction occurs like this. So it is throughout the membrane, because it is all non-insulated, so throughout the membrane it is slower. So this is called as saltatory conduction. So one Schwann cell is there for each myelinated loop, and that Schwann cell myelinates the nerve. In between there are nodes of Renvier where the sodium channels are more. So the electrical impulse jump from 1 to 1, 1 to 1, and leading to a velocity of almost, yes, 35 to 75 meters per second, which we record in our recordings. सो आई कैन कंटिन्यू ऐसे ही, आपको फिजियोलॉजी तो एटलीस्ट बता देती हूँ. इट इनिशिएट्स एट द एक्सॉन हिलॉक, एंड देन देयर इज Yes, ma'am. Ma'am, principles had three. Once we give electrical stimulation, there is initiation of a nerve transmission. Then there is propagation of that nerve transmission through that nerve. And then there comes the synapse, where the nerve is to NMJ and the muscle. So that synaptic transmission, then there comes muscle, and then stimulus या movement that occurs. So it starts from the axon hillock. पहले तो एक रेस्टिंग मेम्ब्रेन पोटेंशियल है. यूजुअल मेम्ब्रेन्स की ऑलमोस्ट -50 30 to 50 होती है मैम. नर्व्स की दे आर मोर -80 to -90. Once we apply a stimulus, there is change in potential. So this sodium and potassium channels जो हैं, जो ATPase pumps हैं, they become active. Now it's their time to open the gate. The sodium channel opens the gate. There is activation and inactivation gate. So it is activated, sodium is going in, this also is closed. So sodium is going inside, there is depolarization. So whenever there is a change of 10 to 30 millivolt, that is threshold. So when there is any change of the 10 to 30 millivolts, there is there is depolarization of the membrane. So once there is depolarization, this inactivated channel, it opens. So it doesn't allow the sodium movement now. This is refractory period. No more sodium can go in, no more sodium outside. So this is a refractory period where there is no transmission, no electrical thing. So the movement is now forward only. It cannot go backwards. So it is forward. It goes in the nerves, in the axons, those who are not myelinated. So it will be like this. So there is no myelination. It will depolarize, it will go on. Now it will depolarize, it will depolarize, it will go forward in that direction. In myelinated ones, this is insulated area. So no current will flow here. Nodes are Renvier. बहुत dense sodium channels are there. Lot of sodium channels are there. So they depolarize and they cause sudden change in potential. So from here to here, they jump like this. From here to here, they jump like this. And this is called as saltatory conduction. हर एक्सॉन के मैम जो माइलिनेटेड पार्ट्स हैं, देयर इज अ स्वान सेल विच प्रोड्यूस माइलिनेशन अराउंड देम, and each segment has one swan cell which myelinates. So this is saltatory conduction. So it is the property of myelinated nerves, and these myelinated fibers, they conduct faster, and that only we can record in our nerve conduction study. So it leads to almost 35 to 75 meters per second of speed. That is 50 times more than the non-myelinated ones. So these are the largest fibers. Then comes the synaptic transmission. So there is nerve ending, there is a neuromuscular junction, and this is the muscle membrane, and these are the receptors and channels where, so now electrical current has come here to this point, to the nerve, to this end of this neuron. So there are this acetylcholine, these are the neurotransmitters which are responsible for the nerve transmission. So they are vesicles containing acetylcholine substance, and when there is current inside, these calcium channels, they got opened. So when the calcium is going inside, it is causing some enzymatic process leading to fusion to the synaptic vesicles. These synaptic vesicles, they got fused to the membrane. There is release of acetylcholine into the synaptic cleft, and these acetylcholine substances, they bind on the acetylcholine receptors in the membrane, and they produce motor end. They are on the motor end plate. They produce compound motor action potential. So this is the mechanism of transmission and different amplitude which is produced at the level of muscle. For nerve, there is no NMJ. So through the nerve, the maximum number of nerves that is stimulated, they produce a summated potential of SNAP, which we call as SNAP, sensory nerve action potential. So most of the fibers this produce this SNAP, and most of the fibers of motor, they produce CMAP, compound motor action potential. So what we record actually? We record there is volume conduction. We cannot see that nerve, we cannot stimulate directly that nerve. So whenever we stimulating that nerve, so it is going through the tissues, fascia hai, tissues hain, soft tissues hain, fluid hai, and everything. So there is a volume conduction in that area when we stimulate a nerve. So that volume conduction which we produces a near field potential which we record. So why we get these waves, that is the basic for that. So suppose we put an active electrode here. For recording we put electrodes. One is active, one is reference. Two electrodes are put. One for stimulating the one is stimulator. I will show. So two electrodes are used for recording the amplitudes and other parameters. So once the active electrode is here, we are stimulating here proximal to it. So there is volume conduction. Through the volume conduction the transmission goes. So there is three phases: towards the electrode, just beneath the electrode, and then when it goes out, away from the electrode. So when the current goes towards the electrode, there is a negative deflection. By convention we say it is as a positive deflection. That is negative deflection, but we call it positive peak, then negative. It is at the electrode, and then again when it goes away from the electrode, it produces a deflection. So a triphasic kind of deflection is produced when a amplitude is recorded. So whenever a C map or snap is there, a triphasic is there, because we are putting the electrode over that area where we suppose that nerve is there to record through the volume conduction. When it goes towards the electrode, at the electrode, and beyond the electrode, there are three phases which are there. Okay. एंड अगर हमने एक्टिव इलेक्ट्रोड बिल्कुल प्रॉपर पोजीशन पे ही रख दिया है, आपको लगता है कि मसल और नर्व उसके बीनीथ ही है, then we can get this biphasic response also, because towards that electrode we are missing, at the electrode and beyond that we are getting these deflections. Okay, so these are the waveforms. See, this is the nerve conduction machine. Here is a monitor, a recorded wave. This is a junction box where the electrodes are there to keep it safe so that the vulnerable parts are not damaged. And there is amplifier inside. These are the electrodes which we use. This is active. This is reference electrode kept at a distance of almost 2.5 to 4 centimeters. And this is the ideal distance, because if there is change in this distance, so different in amplitude or latency can be found. So these are electrical errors which we made. This is a ground electrode, and this is the stimulator. The stimulator had 2 points, one is cathode and one is anode. Cathode we keep towards the electrode, anode towards more proximally. So what parameters we study? So we have electrodes, uh, we uh, we have filter pass to just uh, these electrical artifacts we want to that they should not come. So we use filter pass for that. Different tissues के लिए जो होते हैं वो use करते हैं. And then gain is the vertical extent. Sensory and motor के लिए gain different होता है. Gain is the vertical extent of measurement. For motor we keep at as 5 millimode per division. So we have divisions in our one monitor. So we have 10 divisions suppose, and vertical also 10. So for one division we keep amplitude of uh, 5 millivolt for motor conduction and 10 microvolt. So based on those divisions you can calculate the amplitude. And in the horizontal axis there is sweep speed. So sweep is kept for the duration of that amplitude. So sweep is usually kept as 1 to 2 millisecond per division. So we have division the monitor, so 2 millisecond per division, and based on those divisions like ECG, so based on those divisions we calculate the duration of that particular amplitude and for that particular waveform, and amplitude by this gain. So based on the gain and sweep speed, we calculate duration. Intensity is the current stimulation. In different sensory and motor, we use different intensity of current. For motor, we need more current threshold, and for sensory, we use lesser current region. I will tell later. So these are the differences in motor and sensory. I already told you that gain in motor we use 2 to 5 millivolt per division. For sensory, because sensory are smaller in amplitude, so we use microvolt for them. Current, usually high threshold for motor, 20 to 50 milliampere, sometimes 100 milliamperes also we use. Once we say that this nerve is not being stimulated, up to 100 milliamperes we use for motor. But for sensory we use lesser, because once we start from a lesser threshold of current for sensory, because if you use more current then motor stimulus starts coming, so we cannot get that sensory one, because at lower current the sensory is there. Once you stimulate more, the motor part of that particular nerve get stimulated and you get a motor response. That can, you can confuse with that probably it is a sensory, but there are other differences. From that you can get that probably it is not a sensory, it is a motor one. So motor one, they are larger in amplitude, larger in duration, they are triphasic. Sensory is usually biphasic, but maybe triphasic, smaller in duration. And they are, motor ones are big waves, they are small responses. And for velocity, मोटर के अंदर वी रिकॉर्ड सी मैप, कंपाउंड मोटर एक्शन पोटेंशियल. सेंसरी के अंदर वी रिकॉर्ड स्नैप, सेंसरी नर्व एक्शन पोटेंशियल. These are the most of the nerves potential. So this is the maximum amplitude which we record. For conduction velocity in motor, we record at 2 points. One is distal and one is proximal. And for velocity, वो ऐसा इसलिए है because in motor nerves I told you in the anatomy that there are motor anterior horn cell, motor nerve. वो I will go back to, yes. So motor nerve के अंदर there is anterior horn cell, motor root, motor nerve, and then there is NMJ and muscle. So because if this NMJ and muscle, that will also come into velocity calculation. If we stimulate just 1 point, अगर हमने यहाँ पे स्टिमुलेट किया और थिनार को यानी मीडियन नर्व को स्टिमुलेट कर रहे हैं, थिनार एम्पलीट्यूड्स रिकॉर्ड कर रहे हैं, इफ वी कैलकुलेट, वेलोसिटी का फार्मूला होता है जस्ट डिस्टेंस बाय टाइम. सो डिस्टेंस एंड टाइम जो होता है उस पर अगर हमने सिर्फ डिस्टेंस कैलकुलेट किया फॉर 1 point ओनली, तो विल गेट दैट एन एम जे एंड मसल ऑल्सो इंक्लूडेड. सो वी वॉन्ट टू एक्सक्लूड दैट to get a proper conduction velocity. We take 2 points. So one is distal, we stimulate, we calculate distance. One is proximal, we stimulate, calculate the distance. So this part is excluded, the admg and motor one is excluded. So 2 point is calculated and based on the distance the conduction velocity is measured. Whereas in sensory के अंदर we don't need it, because there is no motor, nothing is there except for that sensory nerve. So we just stimulate at 1 point, we measure the distance and we calculate the velocity. So these are the recording areas. I already told that these are active electrode, two electrodes active, reference, one is ground, this is stimulation. This is thenar muscle which we recording for median nerve. We are stimulating median nerve here. So usually stimulation के distance भी fix होते हैं, almost 3 to 4 centimeter just proximal to that area we stimulate, because this may change the latency also, velocity also. So these are the technical errors which we do. For sensory, we have two techniques to record. 1 point stimulation is there, one side recording is there, but we have two techniques. One is orthodromic, one is antidromic. Orthodromic means from that we stimulate here and we put electrodes on the nerve. So that is orthodromic, means towards, against the receptors. So receptors are there, if we are stimulating towards the receptor, this is antidromic. I mean we are stimulating here and recording here, it is antidromic nerve conduction. And we are recording here and putting electrodes here, so that is orthodromic. Usually in normal practices we use antidromic for sensory nerve conduction, because it is closer to the nerve. So when we recording electrodes are here, we are digitally we are closer to the nerve. So sensory nerve conduction के अंदर issues होते हैं electrical errors के बहुत ज़्यादा, because the small potentials are small, latencies is small, so it is very difficult to record sensory nerve action potential. So errors are more, electrical artifacts are more, so we usually do antidromic, so that nerve is near, we stimulate here, there is more chance to get the snap, when we stimulate here and record here. But when we put electrode here to record it, there are a lot of tissues going on. Carpal tunnel hai, lot of tissue hai, thick hai. So nerve recording is difficult. Errors are more. So that is why antidromic is preferred. But the disadvantage is that antidromic ke andar we stimulate motor nerve also. At times, if you are supramaximal stimulation, if you are going more current you are giving, then more chances of motor activation is more with the antidromic. So it is easier to do, all usually done in labs, but you have to be cautious that you are not stimulating a motor nerve, so that you are into a sensory. So these are the nerve parameters which we record: latency of that particular amplitude, whether it's sensory or motor, amplitude of that snap or CMAP, velocity, as I told you, the 1 point in sensory and 2 point recording in motor. So duration also we measure, area, and few late responses we measure in special cases, F and H. So this is a normal response for a motor nerve. This is a normal response for a sensory nerve. So motor nerve, by visual impression you may see that this is a bigger one, they have longer duration, so their latency is also longer, and they are in millivolts, they are in microvolts. So this is CMAP, this is SNAP. So nerve conduction के जो normal parameters होते हैं, we have a latency. This is electrical stimulus artifact, that you are giving a current. At times this also is missing, so you know that there is some problem in the machine. Electric current, you are increasing it, no nerve is getting stimulated, but you are not at times, and at the same time you are not getting that stimulus artifact also. So you know that there is technical error, so you have to have this electrical stimulus. So this is electrical stimulus that the current is given, from there this is the latency. From the electrical stimulus to the initial deflection, either positive or negative, whichever is there. If it is triphasic, it will be negative one. It is a biphasic, so like here the initial deflection we measure as latency. This is the latency. So this is normal latency for different nerves, they are different. So in the lower limbs they are more, in the upper limbs they are less, because depending upon the nerve fiber length. So actually I forgot to give to take one nerve conduction was there on my table. So I could have shown you. So this is latency, and this is amplitude. For amplitude, from the negative to maximum positive deflection, or from the baseline to maximum positive deflection is measured. This is amplitude. So gain is already mentioned here, to based on the divisions. So if we get 3 divisions, so 2 millivolt is in one division, so 3 will be 6 millivolts for that particular nerve. Duration also is calculated in same manner, 2 millisecond for one division. If it is in 3 division, so it will be 6. So for motor, usual duration is roughly 3 to 2 to 4 or 3 to 6 milliseconds. For sensory it is 1 to 2 milliseconds. Sensory में issues होते हैं to for onset latency, because it is very difficult to record. Lot of artifacts are there, so onset is very fuzzy here. So onset is very difficult in sensory, especially orthodromic current, then it is more difficult. Antidromic may still we can get this onset. So two type of latencies are recorded in sensory. Motor में clear cut latency is there, but for sensory we record onset latency and peak latency. So peak latency is very easy to get. So usual recording जो आप देख रहे होते हो on your nerve conduction report, we record peak latency because that is easy to do, and that is, there is no inter-rater variability as such. If you rate, I rate, it will be like same, but for onset it may vary. Even a smaller variation leads to latency differences. It is very, this cursor is very important. If you wrongly put it here, it will be like latency is prolonged, but you have to put this because this is manually done. The machine also does, but at times we also look it and do it so that it is correct. At times machine does errors in that. So cursor, putting the cursor on the point for amplitude, for this sometimes the this also is biphasic, to we have to put on the lower one. So that adjustments we have to make to avoid those technical. So for sensory we measure peak and onset के भी अपने issues हैं. For all practical purposes we use peak, but issue is that the onset denote करता है fastest conducting fibers. I mean the those fibers who are fastest one among all fibers, that will denote the onset. यहाँ पे शुरू हो गया nerve, and the peak means most of the fibers. So peak से अगर हम latency velocity calculate करें तो it will be lower than what we get at onset. Actual velocity नहीं होगी because fastest we have missed. So हर nerve में हम fastest जानना चाहते हैं. The nerve conduction we want to know the fastest because that is also we are recording, and that we want to know. So that difference comes into that velocity measurement. Otherwise, for practical purposes, we use this peak latency. That is easy to do. For amplitude, yes, from the baseline or from the negative deflection to positive, we use. Yes, yes, this one. This is this is the stimulus from no, ये है एक्चुअल कैलकुलेशन तो यहाँ से ही शुरू हो जाता है स्टिमुलस से वो ले लेगा एंड दिस इज दिस पॉइंट फ्रॉम हियर टू हियर यस एंड हियर फ्रॉम हियर टू हियर स्टिमुलस से लेके जहाँ भी डिफ्लेक्शन हुआ फर्स्ट आइदर नेगेटिव और पॉजिटिव इट विल टेक उसके लिए मैंने बता दिया डिस्टेंस बाय टाइम इज वेलोसिटी फॉर मोटर we take 2 points to just avoid the NMGN muscle and for sensory so this is distal stimulation this is proximal stimulation we divide latencies both and by the distance measurement we measure it actually with the tape some distance and if you make errors in measuring the distance also because limb position also matters if the limb is kept like this limb is kept like this limb is abducted so the distance also how you measure that also defines the velocity so it has to be very in a very particular manner sensory का मैम जो मैंने बताया था the anatomical difference of DRG which is there outside the spinal cord and जो DRG है उसके proximal and distal in the anatomy yes so based on the lesion whether it is proximal or distal the snap varies so अगर distal है lesion then only the snap will be abnormal proximally it is normal so गैंग्लियोनोपैथी के अंदर इसका रोल आ जाता है द वेयर इज द लीजन सेंसरी के अंदर वी हैव दिस सो नॉर्मल स्नैप अगर कॉर्ड के अंदर है प्री गैंग्लियोनिक है देन आल्सो नॉर्मल स्नैप इफ इट इज पोस्ट गैंग्लियोनिक देन द स्नैप इज एबनॉर्मल सो फॉर मोटर एंड नर्व ऑलरेडी टोल्ड इट इज मोटर वन इज इजियर टू डू ज़्यादा एम्पलीट्यूड के होते हैं बिगर होते हैं correctness important है where you keep the electrode stimulator if we keep at the nerve the maximum amplitude we get that also is a technical error if you keep away from that particular nerve so amplitude and latency also varies then there is late responses F and H F response is produced because of the proximal conduction when we stimulate here one transmission is there orthodromic one is antidromic so it goes to the anti-horn cell and again back to the nerve it comes in the form of F wave so one produces M response distal to that stimulation is M So once we stimulate, the correct current is going orthodromically towards the motor. It produces M response, which we see, that is C map. One transmission is there backwards, so to the anterior horn cell it again backfires, so it is a late response after M response. So first there is M response, and then after some time there is another wave coming, that is F response. Importance of F is knowing the proximal lesion. If nerve conduction is normal, M response is normal, but F is M normal, F is not getting recorded, it means there is proximal involvement, means radicals are getting involved. So if the radicals are involved, the backfiring again to the muscle is not occurring, so F is not there. So minimum F latency we measure, these are F response, this is M response, and after some time we get F. So the minimum latencies we measure, we see chronodispersion. Chronodispersion means normally there should be limited in one time period, time frame, like this. So if they are wider, far, so that is chronodispersion. It means one is coming first, then another is coming after some time, so that is chronodispersion, which is a feature of demyelinating lesion. Demyelinating lesions are usually proximal, so F wave abnormalities are usually seen in demyelinating lesions because radicals are getting involved. Chronodispersion is seen, impersistence of F wave is seen if we are getting less than 50% of the nerves having F wave only, then it is impersistent. Ideally all the nerves, more than 80% nerves should have at least one F response after M, so that is F wave. Another is H reflex. H reflex is usually a, yes, for 1 hour we give 10 stimulation, so that is 10 stimulus. So for one, and we give supramaximal because we stimulate, one has to go orthodromic to stimulate this, produce M response, then it has to go travel backwards to the anterior horn cell, then again come and produce a F response. So we give supramaximal stimulation for F. Normally जितना हम stimulation देते हैं, we give 25% extra to get a supramaximal stimulation, so that most of the fibers are stimulated, so that F wave can be produced. So it has to be supramaximal, then we can record an F. It has to occur at a latency. In upper limb it is almost 30 to 32 milliseconds. In lower limb it is longer, 40 to 45, depending upon the height and age of the patient. And then this F is minimum latency is recorded. So that is F. Out of the 10, if it is present in 80, yes, if it is present in less than, I mean less than 5, so that is impersistent, that is abnormal. If minimum F latency which we are getting, that is longer, it is longer in upper, longer in lower, that is latency prolongation. Earliest finding वही होती है. Then we get impersistent, then we get chronodispersion, I mean wide spread. So chronodispersion हमें C map में भी नजर आएगा. C map will be wider, the whole area will be wider. So अगर demyelinating lesion है, I will show अभी axonal and demyelinating क्या फर्क होता है, so that will also be wider. So that is the difference. Then is H reflex. H reflex का stimulation है sub maximal. Usually जितना हम current देते हैं, तो whole of the nerve gets stimulated. So for H reflex, this is electrophysiological correlate of ankle jerk. L5S1 का जो रेडिकल है वो H रिफ्लेक्स इलेक्ट्रोफिजियोलॉजिकली प्रोड्यूस करता है. तो अगर हम सब मैक्सिमल स्टिमुलेशन देते हैं, हियर ओनली सेंसरी फाइबर्स दे गेट स्टिमुलेटेड, it goes into spinal cord, there is a synapse, it comes to the motor fibers and produces this triphasic H reflex. Triphasic का क्राइटेरिया वही है जो वॉल्यूम कंडक्शन है, ये बेस्ड ऑन है वॉल्यूम कंडक्शन, क्योंकि हम डायरेक्टली नर्व को नहीं कर रहे, अदरवाइज एक रिफ्लेक्शन आता. सो दिस इज H रिफ्लेक्स. सो अगर हमने स्टिमुलस की इंटेंसिटी थोड़ी बढ़ा दी, then both sensory and motor will activate. So here we'll go to the spinal cord, and from there also एक M produce हो जाएगा तब तक, because we have stimulated motor also. So it will go orthodromic conduction हो जाएगा, it will produce an M, पहले ही आ जाएगा M, and then H will come. ये collision है, here is occurring the collision. And if a stronger stimulus is given, supramaximum दे दिया, तो both these fibers will get activated. Usually हम लोग both normal nerve conduction study में दोनों fibers से stimulate हो जाते हैं. So we are getting mostly M. H के लिए हमें stimulus की intensity में थोड़ा change करना पड़ता है. तो जैसे जैसे हम stimulus बढ़ाते हैं, M आता जाता है, H कम होता जाता है, and gradually only M is there. और अगर आप उससे भी ज़्यादा बढ़ गया, then F will come. So based on the stimulus intensity, there is H. स्पेशल फाइबर्स की स्टिमुलेशन की वजह से, देन देयर इज M, एंड देन सुप्रामैक्सिमल कर दिया तो देयर विल बी F. These are the waves which are produced. यस, इनिशियली एच, जो हम एच का स्टिमुलस बढ़ाते जाते हैं, सब मैक्सिमल से शुरू करते हैं, इट विल गो ऑन इंक्रीजिंग स्टिमुलस इंटेंसिटी, क्योंकि फाइबर्स के नंबर जो होंगे स्टिमुलस की इंटेंसिटी पे वो बढ़ते जाएंगे। इनिशियली एच का एम्पलीट्यूड भी बढ़ता जाएगा, और जब हम उस थ्रेशोल्ड पे आ जाते हैं, व्हेन बोथ द फाइबर्स आर गेटिंग इन्वॉल्व, एम विल स्टार्ट, बट एम विल बी लोअर। जब करंट और बढ़ाएंगे, एम विल बी लॉन्गर, एच विल बी शॉर्टर, एम विल बी लॉन्गर, एच शॉर्टर, then H will disappear and F will produce. So F will be there. So this is the physiology. F H रिफ्लेक्स की जो इंपॉर्टेंस है वो भी रेडिकुलोपैथी के अंदर ही, H L5 H1 स्पेशल केसेस में ही भी डू। So these are the differences I already told. एक में afferent दोनों में ही, इसमें मोटर है, सेंसरी है, साइनेप्स होता है H में, बट F में there is no synapse. That is important. सुप्रा मैक्सिमल स्टिमुलस देते हैं for F and सब मैक्सिमल for एच रिफ्लेक्स। यूजेस अर्ली गुलियन बारे में दोनों ही इम्पेयर हो सकते हैं रेडिकुलोपैथी में, एच। There are artifacts and technical errors. So temperature in cold weather usually we warm the extremities because latencies prolong हो जाती हैं, एम्पलीट्यूड कम हो जाता है, मेनली लेटेंसीज और वेलोसिटी पे काफ़ी डिफरेंस, डीमाइलिनेटिंग पैटर्न नज़र आता है नॉर्मली कोल्ड में इफ़ यू डू इट विदाउट वार्मिंग। सो डिपेंडिंग अपॉन एज, न्यू बॉर्न्स के अंदर जो इलेक्ट्रोफिजियोलॉजी है दैट इज 40 to 50% लेस देन द एडल्ट्स, एंड एट अराउंड 3 years दे आर कंपेरेबल, लाइक एडल्ट्स ओनली दे गेट नर्व कंडक्शन। एजिंग के साथ नर्व कंडक्शन वेलोसिटीज ग्रेजुअली इंक्रीज होने लगती हैं, लेटेंसीज बढ़ने लगती हैं, कंडक्शन वेलोसिटीज कम होती हैं, लेटेंसीज दे टेंड टू इंक्रीज, एंड एम्पलीट्यूड ऑल्सो decreases. These are non-physiological machine related problem or रेटर रिलेटेड प्रॉब्लम, या जो कर रहा है लिम पोजिशन है, एंटीडोमिक, ऑर्थोडोमिक, को एक्टिवेशन, स्टिमुलस आर्टिफैक्ट, फिल्टर्स, दैट वी हैव टू लुक फॉर। तो व्हाट इज द रोल? We just want, through all this practice, we just want to know whether this pattern is axonal or demyelinating. That is what we know in nerve conduction studies. So axonal pattern is commonly seen, there is decrease in amplitude, so this is axonal loss. Latency will remain same क्योंकि fastest conducting fibers already are there. Axonal loss is happening but myelination is intact. So fastest conducting fibers are there, so they will fire. Latency will be same, but because the maximum number of fibers are not there, the volume is reducing. So there is decrease in amplitude. Velocity will also be same. So here normal distal stimulation decrease amplitude, proximal stimulation decrease amplitude. That is the abnormality in nerve conduction. So amplitude we have to know, normal parameters होते हैं based on different lab, from there we have to compare, already machine के अंदर होता है. For demyelination there is change in latency. So because of the myelin loss, the saltatory conduction is not being there, a smaller number of fibers are there to fire, so the latency is increased, and because latency is increased, velocity is obviously it will decrease because we calculate from that only. So our amplitude usually remains same until unless it is very severe demyelination that the conduction is not happening, it's like no non-recordable amplitudes. So in that case we can get a decreased amplitude. In demyelination only we get conduction block. Distal stimulation पे ठीक है, but proximal पे there is decrease in amplitude, that is conduction block. If there is 50%, more than 50% drop in amplitude in proximal and distal stimulation, that is conduction block. तो टेम्पोरल डिस्पर्शन मैंने बता दिया कि जो डीमाइलिनेशन होगा उसमें नर्व का ड्यूरेशन होगा, बिकॉज अलग अलग फाइबर्स डिफरेंट टाइम पे स्टिमुलेट होंगे, सो देयर विल बी लॉन्गर इन ड्यूरेशन, ड्यूरेशन लॉन्गर होगा, लेटेंसी प्रोलॉन्ग होगी. So localization we do clinically only, and based on the clinical findings, based on the nerve conduction, we can get whether these nerve conduction abnormalities are pure, we are getting into pure sensory, pure motor, mixed pattern of involvement, it is axonal or demyelinating or mixed pattern, and based on the temporal course we can diagnose. So the cardinal rule is that it is the extension of clinical examination. Question whether the finding of electrodiagnostic are relevant to your clinical problem. When in doubt, think about technical factors first rather than rating the nerve conduction as abnormal. Re-examine the patient whether we are actually correlating with the nerve conduction findings. Always think about clinical and electrophysiological correlation. That is most important. And when in doubt, do not overall overcall a diagnosis. So that is the principle of nerve conduction. That is all, ma'am. Thank you. आई थिंक आप लोगों को थोड़ा बहुत if you have nerve conduction reports, then I can I mean, question or based on that report, then I can discuss. Or so तो नर्व कंडक्शन की रिपोर्ट जब हम देखते हैं तो हमारे पास नर्व कंडक्शन के अंदर बहुत सारी चीज़ें हैं। सबसे पहले टेबल्स बनी होंगी, उसमें ऊपर लिखी होगी मोटर नर्व कंडक्शन स्टडी, फिर होगी सेंसरी नर्व कंडक्शन स्टडी, फिर मोटर नर्व कंडक्शन स्टडीज़ के अंदर डिफरेंट नर्व्स लिखे होंगे, राइट मीडियन। यूजुअली हम मीडियन से स्टार्ट करते हैं, अपर लिम्ब से ईजी होता है, मोटर से स्टार्ट करते हैं बिकॉज मोटर इज़ टेक्निकली लेस डिमांडिंग, ईजिली हो जाता है। बट इन चिल्ड्रेन वी यूजुअली डू सेंसरी। वो इसलिए करते हैं क्योंकि सेंसरी के अंदर वी यूज़ लेस करेंट। So because once it is painful, the child will not allow to do a nerve conduction. So for children, we do first sensory. हम ये भी देखना चाहते हैं कि sensory is more objective rather than motor nerve conduction. Why? Because अगर मसल atrophy है, कोई किसी की मसल because of nutrition ही atrophy हो गई है, या किसी और प्रोसेस की वजह से, लोकल ट्रॉमा की वजह से ट्रॉफी हो गई, किसी भी वजह से जनरलाइज ट्रॉफी है या फोकल ट्रॉफी है, देन मोटर नर्व कंडक्शन एबनॉर्मेलिटीज कैन बी सीन because there is muscle loss. We cannot record that there is muscle loss. Definitely nerve fiber loss is also there. So motor conduction abnormalities we can get in that also. So sensory nerve abnormality is one thing that is very objective. अगर snap की abnormalities हैं, technically you are right because it is very difficult to record a sensory nerve potential. So technically demanding है, but once you record a sensory, we know that probably motor, अगर GBS को छोड़ दे, one pathology which is purely restricted to motor, most of the other neuropathies we think it is not related to neuropathy because sensory is coming completely normal. For children we do sensory first because electrical stimulation less is required. So सेंसरी करने के बाद ही अगर सेंसरी बिल्कुल नॉर्मल है तब हम दूसरी ये भी देख लेते हैं कि ओवरऑल जनरलाइज बच्चा ठीक है। अगर जीबीएस सोच रहे हो देन ऑफ कोर्स वी हैव टू डू मोटर वाला पार्ट बिकॉज सेंसरी विल ऑलवेज बी नॉर्मल इन दैट। सो मोटर के अंदर मीडियन पहले स्टिमुलेट करते, सबसे ईजी है करना। तो आप देखोगे उसके अंदर सबसे पहले राइट मीडियन, देन लेफ्ट मीडियन, देन देर विल बी ऑनसेट लेटेंसी, पीक लेटेंसी, एम्पलीट्यूड और उसके बाद वेलोसिटी, इतना लिखा होगा। उसके पैरामीटर्स भी लिखे होंगे लेटेंसी के, एम्पलीट्यूड के नहीं लिखे होते क्योंकि वो लैब का अपना है, बट लेटेंसी के पैरामीटर्स लिखे होते हैं, लेस देन दिस, लेस देन दिस, लेस देन दिस, इतना होना चाहिए ना। तो उस लेटेंसी पे आप देख सकते हो कि जो नॉर्मल लेटेंसी के पैरामीटर्स हैं उससे ज़्यादा है या कम है या उतना है। ठीक, अगर उससे कम है तब तो नॉर्मल है, उससे ज़्यादा आ रहा है तो भी डिमाइलिनेशन कहने के लिए भी पैरामीटर्स हैं। इट शुड बी, लेटेंसी शुड बी मोर देन 75%, 125% ऑफ नॉर्मल, मतलब 125% अगर बढ़ता है तब हम लेटेंसी को डिमाइलिनेशन या जीबीएस की तरफ से मानते हैं। फिर अपर लिम्ब के बाद आपको ऐसे एम्पलीट्यूड के अंदर भी, एम्पलीट्यूड में कंडक्शन ब्लॉक आप इजीली देख सकते हो। आप उसमें दो स्टिमुलेशन भी लिखे होंगे मैम, डिस्टल प्रॉक्सिमल। डिस्टल का एम्पलीट्यूड अगर 6 है, मान लो मीडियन नाउ 6 मिली वोल्ट एंड प्रॉक्सिमल स्टिमुलेशन इज कमिंग 3 मिली वोल्ट, 2.5 मिली वोल्ट, देन देयर इज कंडक्शन ब्लॉक। सो दैट इज वन पॉइंटर ऑफ डीमाइलिनेशन। यू कैन ऑल्सो सी द ग्राफ, आप ग्राफ देख के भी बता सकते हो। अगर ग्राफ छोटे छोटे दिख रहे हैं, लेटेंसी आपको ठीक ही दिख रही है, लाइकली है कि एक्सोनल होगा। ग्राफ में एम्पलीट्यूड बहुत बड़े बड़े दिख रहे हैं, वाइड अपार्ट बड़ा सा बना है, बट the latency is also prolonged and there is temporal dispersion. From that graph look also you can say that probability is a demyelination. इसके बाद आपके F और H इसके बाद होते हैं, सेंसरी के अंदर भी ऐसे ही होते हैं। तो आपको रिपोर्ट भी पढ़ने की ज़रूरत नहीं है, यू कैन जस्ट सी द ग्राफ्स, यू कैन जस्ट सी द पैरामीटर्स एंड I think that hesitation should now go with the what you ask me. Okay, जो फील्ड पोटेंशियल वाला आप पूछ रहे हो। हम्म, ये इलेक्ट्रिकल इम्पल्स शो कर रहा है, ये नर्व है, इसके साथ टिश्यू भी है, मतलब यहाँ पे ये कोई चीज़ शो नहीं कर रहा है। ये लाइन, सिर्फ ये लाइंस में ये बता रहे हैं कि हम इलेक्ट्रोड, ये करंट यहाँ से जा रही है, यहाँ पहुँची, फिर इसके बाद ये यहाँ आई डिस्टेंस, ये जब आई यहाँ पे तो इसने ये वेव फॉर्म प्रोड्यूस की। सेकेंड ये शो कर रहा है जब ये यहाँ आया जस्ट बीनीथ द इलेक्ट्रोड, तो इसने ये अलग इसने कर दिया है ताकि ईजी हो अंडरस्टैंड के लिए। यहाँ आया तो ये वेव फॉर्म प्रोड्यूस हो गई, और जब ये इलेक्ट्रिकल इम्पल्स यहाँ आ गया थ्रू दैट टिश्यू ओनली, ये टिश्यू वॉल्यूम ही है, ये पूरा पूरा आपके नर्व और मसल के नीचे का टिश्यू है जिसके अंदर ये ट्रांसमिशन हो रहा है। दिस इज, ये नर्व या उसका रिप्रेजेंटेशन नहीं है, ये अलग अलग इसलिए इसने कर दिया है कि ताकि आपको ये टूवर्ड्स आ रहा है, टूवर्ड एट द इलेक्ट्रोड है ना, आउट अवे फ्रॉम द इलेक्ट्रोड, दैट इज बीइंग शोन। नहीं, नीचे वाला ये शो कर रहा है कि आपने जो रिकॉर्डिंग इलेक्ट्रोड है जस्ट अबव द नर्व रख दिया है, मतलब आप इधर उधर नहीं है, जस्ट वही है। तो फिर आपको जो इनिशियल वाला प्रोपोगेशन है वॉल्यूम कंडक्शन का वो नहीं मिलेगा वेव फॉर्म के फॉर्म में, यहीं पे स्टिमुलेशन आपने दे दिया तो यहीं पे एक वेव का डिफ्लेक्शन हो गया, एंड देन व्हेन इट गोज अवे फ्रॉम इट देन देयर इज अनदर वेव, सो दैट इज, तो आप बहुत एक्यूरेट हो अगर इन योर इलेक्ट्रोड प्लेसिंग, सो यू विल गेट अ बाईफेजिक रिस्पॉन्स। बाईफेजिक यही बताता है यू आर मोर एक्यूरेट इन प्लेसिंग योर इलेक्ट्रोड। सो इलेक्ट्रोड भी प्लेस करने के पहले वी जस्ट रिमूव द डर्ट, क्लीन इट, we try to place it at a proper place, तो ट्राईफेजिक और बाईफेजिक उस पे। थैंक यू मैम। नहीं, जैसे मैंने कहा कि 3 इयर्स पे नॉर्मल नर्व कंडक्शन, क्योंकि वी आर डूइंग एडल्ट्स ओनली, तो हमारे पास नॉर्मेटिव डेटा फॉर चिल्ड्रन इज ऑल्सो नॉट देयर, सो बट beyond 3 they follow same pattern as adults based on their height and weight and everything, BMI, that latency and velocity will differ, so that will definitely be different from an adult, that a lab जो होगी वो उनके अपने पैरामीटर्स पे ही होंगे, बट यूजुअली हम आपके भी बच्चों में वही यूज़ कर रहे हैं जो हमारे पास है, बट ये है कि लेंथ भी हम मेजर करते ही हैं तो इसलिए नॉर्मेटिव डेटा तो वही यूज़ कर रहे हैं, बट वी डोंट हैव नॉर्मेटिव डेटा फॉर चिल्ड्रन, स्मॉलर वंस स्पेशली। हम्म, नहीं डिफरेंट नहीं है मैम, वो एक तरह की पूरी वो होगी कि आपको बड़ा सा एक पॉपुलेशन लो जिसमें जो नॉर्मल हो, है ना, नॉर्म। हम्म, नहीं होगा मैम, पीडियाट्रिक न्यूरोलॉजी में जो कर रहे होंगे उनके अपने सेटअप होंगे, वो रेगुलरली उन बच्चों का कर रहे होंगे तो वो जनरेट कर लेते हैं, हम लोग भी कर रहे हैं बट हम लोग अभी उसी डेटा पे। नहीं, ये एक्चुअली एथनिसिटी, हाइट उस पर डिपेंड करता है, तो कोई भी ऐसा डेटा जो आप वेस्टर्न वर्ल्ड के लिए है वो अपने लिए यूज़ नहीं कर सकते, उनके लेटेंसीज डेफिनेटली ज़्यादा। करते ही है मैम, बिल्कुल कर सकते हैं यूज़। हाँ, बिल्कुल बिल्कुल कर सकते हैं, अगर वो परमिट करते हैं अपना डेटा यूज़ करने के लिए तो बिल्कुल, क्योंकि वो उनका अपना वो होता है वैसे ही डेटा है ना, जैसे हम हर हर क्योंकि वो कुछ ग्रुप को करके करते होंगे, नॉर्मल बच्चे होने चाहिए जिनका डेटा आपको चाहिए, हम लोग डिजीज़ को कर रहे हैं।
So, on the behalf of Department of Pediatrics, I thank Dr. Shweta
Thank you,
for
ma'am.
coming here, and you have made this difficult topic easy for us. Hopefully, we will remember all those things you have taught to us. So thank you.
Thank you, ma'am. Thank you. Ma'am, one photo, ma'am. Ah, sure. So he's going to take. Light